Hi, I'm Dr. Haas. I'm an endodontist from Toronto, Canada, and I want to thank you for joining me for this webinar. It's a webinar about something that's, believe it or not, quite dear to me, something I love to talk to colleagues about, and it's about obturation, especially carrier-based obturation. The reason why I love to talk about this is because I see it so often where colleagues try their best to do root canals, they instrument really well, by the time it comes to obturate, this is where they start having issues. And so I really do want to try and help you and colleagues out there, and your patients, of course, perform root canals and obturations better and more predictably. And as cheesy as that may sound, I really mean that. So I do also want to mention, if I may, that I have no financial interest in any dental product or company whatsoever that I talk about, and I am not being compensated whatsoever for this webinar. So what I say is what I mean, and it's something, again, that I love to talk to colleagues about, and this is why I'm doing this. So in terms of the outline for this webinar, I'll cover quite a few things. One of them is traditional warm downpack obturation with backfill. The other will be about carrier-based obturation, and I'll give the sort of step-by-step of both systems, and the good and the bad and the ugly, so to speak, of these systems. And I'll also give a lot of clinical tips along the way. These are things that I learned over the years from performing both systems. And something that I love to talk about, which is almost like a little pet peeve of mine, is misconceptions about carrier-based obturation. So I'll talk about that certainly at the end. So to start off, I do want to mention that there's a clear trend in endodontics when it comes to instrumentation and obturation, and that involves sort of simplifying the protocol for the technique, whether it's instrumentation or obturation. It all started when, I feel, when WaveOne came out, when Dentsply introduced their WaveOne file. This one file, all of a sudden, overnight, sort of revolutionized the way we look at instrumentation, and we realized that with this one file, this one workhorse of a file, we could do what it took multiple files to do. So the same with obturation. Now the WaveOne file then moved on to the better, the new and improved system, the WaveOne Gold, still with the same idea, being able to perform what we need to do with fewer steps. And that's really thanks to improved engineering and armamentarium and materials that are out there. So altogether, what it really means when it comes to obturation and instrumentation, with the new and improved systems and engineering that are out there, we can do things with fewer steps, which means things are simplified. That being the case, things also come out more predictably, there's less room for error, and the technique itself becomes better and simpler to perform. It doesn't mean we're cutting corners, it just means we can do something just as well, if not better, but also in a more simplified way. This is where we are this day and age. So with that said, let's get into obturation. So when it comes to obturating this tooth that you see that was cleared by Dr. Hess about a century ago, we know that we have to obturate all little nooks and crevices, the lateral canals, the isthmuses, the fins, apical deltas, all these little nooks and crevices of a tooth and of a root canal system. And if you want to obturate this in a three-dimensional way, as we often say, then it really comes down to two main systems. One of them is as you see on the bottom left, the downpack with a backfill technique. And then the other one on the bottom right is a carrier-based obturation system. I'll talk about both of them. First, I'll talk about the more traditional downpack with backfill technique. That means we're putting our Gutta Percha in there, we're sort of searing it off, and then we're backfilling the canal with warm Gutta Percha to try and simplify it for now. What all these systems have in common is that nowadays they all use single-use cartridges, which is really nice, Gutta Percha cartridges, to simplify the protocol, the setting up, the cleaning up, and so on and so forth. They also have their extrusion that is motorized now. And so that also makes the procedure hopefully a little bit easier. What they also have in common, and they've always had in common, no matter what, unfortunately, is that they involve many steps. And that being the case, they're also very, very technique sensitive. There's no way around this. And if you want to obturate with a warm downpack and a backfill, to do it properly, you really have to follow all these steps that you see on the screen right now. To try and go through this quickly and efficiently, so I don't keep you for too long, really what it involves is first you have to pick your Gutta Percha, your master Gutta Percha cone. You got to make sure that the Gutta Percha cone fits the canal well and that there's apical tug back. And then you got to pre-fit your pluggers, your hot instruments, and I'll talk about that in a moment. And then you got to put a little bit of sealer in there. You put in your master cone, hope that there's tug back apically, sear it off at the orifice. And then you got to take your hot instrument put it inside the canal where the gutta percha is, and heat the instrument, heat until you're about 4 or 5 millimeters from your working length. Now that heated instrument is connected to the gutta percha that's remaining at the apex. If you just take that instrument out, what happens is, unfortunately, now you may pull out the gutta percha at the apex. So to avoid that, you put in your hot instrument, you leave it down there, you take your finger off, so to speak, off the hot instrument to cool it off. Now it's a little bit of a plugger. You push it apically about maybe 1/2 millimeter or so. You got to turn that plugger and then heat it up again and then take it out, and you hope that the gutta percha stays at the apical third. You hope, okay? And then after that, you got to go in a little bit more sealer, put in your basically your injection gun, so to speak, which means the tip that is injecting the gutta percha now has to go all the way and touch the gutta percha that's remaining at the apical quarter or apical third. It's got to touch that gutta percha, because if it's not, then you're going to create a void. So hopefully it's touching that gutta percha. You let them melt the gutta percha interface there. And then you start to backfill this and pull it out to backfill. Then you take your pre-fitted plugger, depending which one it is, depending which canal you're working on, plug it apically, take that out, and now you got to go back in there again with your hot instrument. And so there are multiple steps in there. Along the way, you got to add a little bit more sealer in there. So there's no way around it. To do it properly, warm obturation with the traditional downpack technique involves quite a few steps. And the more steps that there are, the more technique sensitive the system is, and the more things can go wrong. When it comes to fitting your plugger, this is before you even put your gutta percha in there. As you see in this little video over here, you have to pre-fit your plugger to be about 4 or 5 millimeters from your working length. Then you take your next plugger, to a larger one, to be about 4 or 5 millimeters shorter of that, so let's say 8 to 10 millimeters short, and then take another plugger to be, again, about 4 or 5 millimeters away from that again. So you got to do all these steps just for one canal before you even put in your gutta percha in there. And then you also you have to fit your hot tip, regardless of the system you're using. So you're going to put in that hot tip. Very important that that heated instrument goes to about 4 or 5 millimeters of the working length. You pre-fit that, set your rubber stopper on there, go into the next hot tip, the larger size, pre-fit that one, and then keep doing that. Again, this is all for just one canal. We haven't even started our obturation really yet. And it's very important to make sure that your initial plugger actually goes to about 4 or 5 millimeters of your working length, because if it doesn't, then you're actually not warming up the gutta percha apically. Okay? That's something to keep in mind when we talk about obturating curved canals later on. That being said, you put in all those instruments aside. We're not starting yet. Now you got to fit your master gutta percha cone. So you're going to go in there, and as you see in this little video, you're going to put in your master gutta percha cone. You got to make sure that you have apical tug back, not mid-root tug back. You got to have tug back apically. If you don't, what you do is, you see what I'm doing here with the scalpel, is you cut the tip of that gutta percha point, that master gutta percha point. Try and fit it in there, see if there's any apical tug back. Nope, still no tug back. Cut again a little bit more, put it back inside the canal. Keep doing this until you have apical tug back. And again, you put that gutta percha aside, you got to do it for every single canal. We haven't started even doing anything. Okay, we haven't even started with the sealer in the canal. Once you're happy that you have your gutta percha, and then now you can start putting some sealer inside the canal. The thing though is that when you have to put in your master gutta percha cone, if you don't have good apical tug back, what happens is, as you try and sear off the gutta percha at the orifice, so we're just starting here, as you try and sear off the gutta percha at the orifice, if you don't have good apical tug back, the falling will happen. The whole gutta percha will come out. I'm sure we've all been there. I've been there a million times. I see it with my students, colleagues. Very often I see this, and we barely even started our gutta percha. So imagine if this happens, then we've got to go all the way back, find another master gutta percha cone. Whatever we thought we did well the first time around, well, we didn't. So we got to redo that, make sure we do have good apical tug back, and then continue with our obturation. Now, what we see, however, could happen very easily with the problems with the warm obturation is that we could easily get voids in the canals. Again, like I said earlier, if that hot instrument, or the injection gun, I should say, of the gutta percha, if it doesn't touch the gutta percha at the apical part of the root, then you're going to get a void in there if it doesn't melt that interface. Or if your plugger goes in there and you don't fill that void that the plugger creates, then you're going to get these sort of plugger tracks, as you see in these radiographs. So this is a very frustrating thing to happen, because if this happens, then I sort of have to almost retreat that canal, and this gutta percha by now becomes very sticky and gooey, and it's almost like a full-on immediate retreat that you have to do. And whatever problem led you to do this, well, you got to now make sure it doesn't happen again. So it's not that simple to overcome. So this is a common frustration, especially if you don't do that many obturations, or you're not as experienced with this. So keep in mind, either when it comes to worm obturation, you do what you see in the top here, and you follow all these multiple steps per canal. Either you do this, or if you want to do 3D obturation in a more simplified way, more predictable way, but still have full worm 3D obturation, then just think about this. Wouldn't it be easier and faster and honestly more predictable to do the following? So you be the judge. I'm going to show you what I mean. So here's a case, a lower molar that I did, and I'm obturating the distal canal of this lower molar. So remember the 15 or so steps that were in that image before in the previous slide? Either we follow all those steps for that canal and all the time and hassle and whatnot, or you do the following, as you see in these videos over here. We're obturating the distal canal. So we're taking this hot gutta percha that is on a carrier, and we're counting to about 8,000, so 7,000, 8,000 seconds. We're counting to about 8 seconds or so, and that's it. Done. No gimmicks, no editing, nothing. That's it. We are done. It is obturated, period. So, and this is what we get at the end. Pretty simple. This is simply because of just good engineering that we have available this day and age. Good engineering, good materials. This is what we can do this day and age. And how long did it take? It took about 8 seconds to do this canal. Okay, again, no gimmicks, no editing. I'm not trying to be slick or anything. It took about 8 seconds to obturate that single canal. And you see finally how it looks at the end. So what's the catch, you may ask? You think there's got to be a catch. Can't be that simple, okay? Well, there's two things. The first catch is the following. If you can do the following, then you should be able to obturate with this carrier-based obturation. And it's this. If you can insert a paper point into the canal without touching the walls of the endo axis, and I'll give you about 7-8 seconds or so to do that, then you should be able to follow this technique. This is what I mean. Imagine you have this canal and you're drying the canal of your intracanal medicament or lubricant just before you're about to obturate. Well, we use paper points all the time. It's not even an issue. We don't even think about the trouble, the hassle of putting paper points in canals. So if you could do the following and just put in your paper points inside the canals without touching the walls of the endo axis, as you see in this video, then yeah, you could do this technique, okay? And you do this all the time, right? This is nothing you even think about. This is catch number 2. If you can match colors, and I'm not trying to sound silly here, but if you can match colors, in other words, the color of the master file with the color of the obturator, then you should be able to do this carrier-based obturation. In other words, here you see this WaveOne gold file. If you can match the color on the handle of that file to the obturator, okay, then you should be able to do this technique. Sounds silly. I'm not trying to sound smart here or silly about it, but I really mean it. So it's those two things. If you can put in a paper point into the canal without touching the walls, and if you can color match it, then that's it, okay? It's just we get a little bit nervous when we think about, oh, I've got obturation, I got gutta percha in my hand. Imagine this gutta percha as being really well-engineered, well-designed, well-made paper point, okay? Then all of a sudden we don't make an issue out of this thing, okay? So that's really the catch. And it brings me to say, and I have to emphasize this, that GuttaCore, when Dentsply developed GuttaCore, it absolutely was a game changer, because they've listened to people's complaints over the years when there were carrier-based obturations that may have been with a metal carrier or a plastic carrier, which I used to use for years, and I must admit did not like whatsoever because of the hassle with it, especially in obturating posteriors, and the handle getting in the way of the opposing arch. Well, they listened to all these things and said, well, let's come up with a gutta percha somehow with an obturation system that is all gutta percha. We can put it in the oven, warm it up, and now you can obturate with it. But it's all gutta percha, not plastic, not metal. It is gutta percha. It's got cross links and whatnot. I'm not going to get all technical on you. The point is, it is gutta percha, period. It's like ice and water, so to speak. It's gutta percha, it's harder on the inside, and gutta percha on the outside that softens up more. Let's think of it that way, as ice and water. But that's all it is. So overnight, I have to say that this GuttaCore system from Dentsply totally changed things. So when it comes to these obturators, and you see an example of it on the right, is it's gutta percha with gutta percha. So it's almost like some people would call it gutta percha on a stick. That's the term that's been used for years and years. So It's very easy to break off the handle. That's a huge benefit. As soon as I started using the system, immediately I realized you could just break off the handle. You may not think very much of that, but I'm going to show you videos about how that simple little benefit of it, or feature of it, is huge clinically. Absolutely huge. So you can break off the handle. It's Gutta Percha. There's no reason not to. You do not need a ruler. Okay, so you have markers on these Gutta Perchas. The Gutta Percha you see on the right, and even the ones you see on the left, they're actually little notches. The one on the right, you see little notches just below the rubber stopper. Those are the built-in rulers. You do not need to use a ruler. Trust the ruler that's built into this Gutta Percha cone. Okay, and the obturation handle handles like, basically post-obturation, it handles like regular Gutta Percha, because later on in the webinar I'll talk about, well, how do you retreat it? How do you do a post space? Well, it's Gutta Percha. Okay, so I'll show you how that's not even an issue. It's reached the point now where GuttaCore just keeps getting better and better, and it's now so nicely matched and suited for certain files that are out there that it's really nice to see. It just keeps getting, it was phenomenal when it came out. Well, it just keeps getting better and better. So it's nice to see that, and it's truly a very simple system to use. But simple doesn't mean we're cutting corners or we're going below standard or anything like that. Not whatsoever. So that being said, I'll even show you a video here of a common demonstration I do during my workshops. So you'll see this oven. You take this Gutta Percha Carrier based GuttaCore system, you put it inside the oven. When the light's blinking, you take that out of the oven, quite simple. Grab it with cotton pliers, and now I'm going to be putting it inside a tooth, into this extracted tooth, and I'm going to be counting to about 8 seconds. It'll be about 4,000, 5,000, 6,000, 7,000. That's it. Very important to count that, because there's a certain speed that it has to go in for it to flow properly into the canal system to accommodate the viscosity that it has. Believe it or not, that is one of the toughest things about this system. I see it all the time. People either put it in way too fast or far too slow. Usually it's way too fast. Just you're putting into the canal there, 1,000, 2,000, 3,000, 4,000, 5,000, you get the message. That's it. It's as simple as that. It's that paper point that'll give you about 7 or 8 seconds for the average length route to reach the apex. That is the toughest thing, and I'm not kidding. That's how simplified the system is, when that really is the toughest thing out there. And then in this case, in workshops, I love taking radiographs of the teeth that we obturate, and right away we can actually see what's going on. You can certainly do this in your clinic and evaluate your own work. It's pretty impressive what you see there. So there are certain steps that I just want to cover that are very important. Very, very simple. You'll see them once, maybe twice, that's it. You'll never need to remember or think of these again. You'll always remember them. But certain very, very basic steps that I want to cover when it comes to carrier-based obturation. The first thing is you have to use the size verifier. This is a full-on nickel titanium hand file that comes with the obturators. Okay, it's included in there, and it serves 3 purposes. One of them is to clear the apical debris. What do I mean? After we're instrumenting, and even if we're irrigating, there's usually a little bit of a dent and mud that's left at the apical part of the canal, and this is no matter what system you're using out there. So no matter what obturation system you're using, you should always clear the dent and debris or the dent and mud that's left in the apical, maybe 1, 2, or 3 millimeters, because if you don't, then your obturation will not reach length. I hear a common question where people say, Manor, how come I did everything right, I used an apex locator, I reached the working length with my file, but when I'm obturating, somehow the obturation is 2 millimeters short. This is one of the main reasons for it, because you may have some dent and plug left behind, again, no matter what system you're using. So what you have to do is you put in this size verifier, and you're going to be turning it in there, and you got to make sure that the tip of that file comes out free of dent and debris. Okay, it might be clean debris, but it's still dent and debris that's going to block your obturation. If you let's say do have some powder or debris on the tip of the file, fine, then clean the file, put it back in the canal, and keep doing this until it comes out free of dentin. You also want to make sure that the file, the size verifier, this nickel titanium size verifier, is fairly loose inside the canal. If it is, it means you've instrumented sufficiently for the corresponding GuttaCore obturator. If it goes in really, really tight, that means you need to instrument just a little bit more. I often do it with my size verifier, or if you want, go back in with your main master nickel titanium, let's say mechanized file. Whatever it is, it just has to be a little bit loose. So remove the dent and debris and make sure it's a little bit loose in there. It takes 2 seconds to do this. It's really simple, but very, very important part of the procedure. Here's another example clinically of me using a size verifier in the fully instrumented and dried canal. I take it out, there's no dent and debris at the tip, perfect, we're good to obturate. The other thing that the size verifier is used for, the third thing, is it's almost like your mid-obturation confirmation. Because by the time we're done obturating with the GuttaCore, well, that's it, it's obturated. You're not going to take a mid-obturation film. So just to be sure that, okay, you are where you want to be, you put in this corresponding color size verifier, take a radiograph, make sure everything's okay. If it is, again, we're good to go here. So the next question, and I get this quite often, Manor, how much sealer should I use? Or Manor, I get this issue and that issue because I use too much or too little sealer. It's actually very, very simple. We're here obturating with Gutta Percha. We're not here to obturate with sealer. Somehow year after year after year, decade after decade in endodontics, there's just one common theme. We always seem to go back to Gutta Percha obturation. Not a ton of sealer and a skinny little Gutta Percha to put in the canal. And so how much sealer do you put in there? Very little, less than what you think. So here you see on a paper point, I'm putting just maybe the last few millimeters of the paper point, I'm putting some sealer in there. And I'm just going to be coating the canal very gently, going to roughly working length. It's really meant to be more of a lubricant than anything else. Okay, so just very little sealer. How much? Less than what you think. That's how much. You want to obturate with Gutta Percha. The next step then is you're going to have your warm obturator. You took it out of the oven. Super simple step, but very, very important. I want to make your life easier. Okay, and I learned this right away when I started using GuttaCore, is, as you see in this video, grab it with a cotton plier, not your fingers, break off the handle, and now it's like a paper point. You're going to be putting it in there, and again, roughly 7-8 seconds. So 7,000, 8,000, that's it. There we are. And you'll actually see in this block how the Gutta Percha and even sealer even filled the lateral canals. A point I want to mention here is you'll see the rubber stopper was a millimeter short of really the working length it should have gone to. Okay, let's say we instrument it to 20 millimeters, we want to obturate at 20 millimeters, but somehow the rubber stopper stops at 19 millimeters. I see this very, very often, whether I'm using it or whether it's during a workshop that I'm giving that it happens. It's rarely ever an issue. If you've instrumented the canal properly, you've cleared the dent and debris properly, it's nice and dry, then I'd say, from my experience, 9 times out of 10, and as you see in this video, if that rubber stopper is, say, a millimeter short of where it should be, you're fine. So please don't worry. That Gutta Percha it'll fill the nooks and crevices beautifully. If you left that space behind, there's no dent and plug or anything like that, it'll fill that space. I'd say easily 9 times out of 10. So not an issue, but look at how simple this technique was in terms of obturating this thing. It's beautifully simple. I'm going to actually show the video again, if you don't mind. So here I am, break off the handle, grab it with a cotton plier, put it in the canal, and we're counting. 2,000, 3,000, 4,000, 5,000, 6,000, 7,000, that's it. It's more you getting used to the speed I put it, the obturator in the canal that's important. That's why I'm emphasizing the counting. And that's it. You're done. Remember all those 15 steps that there were in those images that I showed you about warm downpack techniques? So imagine all those for this one canal versus this within roughly 7-8 seconds. Okay, this is where we are this day and age in endodontics when it comes to obturation. So how to remove the excess Gutta Percha, let's say it's sticking out of the canal a few millimeters? Not a problem. I used, what I love to use is just a sharp spoon excavator. That's it. Whatever you have in the office that's a sharp spoon for caries removal, use the same thing. Don't go out there and start buying any fancy instruments. Just, you have a caries removing instrument that's sharp, that's it. That's all you need to use. I don't recommend using a hot instrument. I don't recommend using a high-speed burr. Those are things that may have needed to be used, let's say, for the plastic-based carriers, and it got really messy, and it's not that easy. You start nicking off dentin if you use your high-speed. That's it, your spoon excavator. Very, very simple. So let me show you a step-by-step of a clinical case of mine. Okay, so here's a lower molar from sort of beginning the before and the after. And so let's start off with the sealer placement. Okay, so canals are, you're fully instrumented, irrigated, dried the canals, you're good now to obturate. Let's first paint the canals. Just a little bit of sealer. Again, how much sealer? Less than what you think. Now, at this point when you're putting in your sealer, if you're new to using the GuttaCore system, this is a nice little point to sort of mentally start thinking about, okay, now imagine this as being my GuttaCore. Okay, so in your mind, this is almost like a rehearsal for placing the GuttaCore inside the canals. Remember, you're going to put in a paper point, just brush the walls gently with very little sealer. You're not touching the walls of the endo axis. That's all you need to do when it comes to obturating. So you got a little bit of sealer to act as a lubricant. Now we're going to put our carrier based obturation, the GuttaCore, in the oven. It takes about 15 seconds or so. So it's not that long, just enough time to maybe just for you to make sure clinically that everything's in order around you, you got what you need around the patient. And when the light on the top right side will start to blink, that little circle over there, then it means good, we're ready, it's warm enough. And now we're going to take out the obturator and grab it with the cotton plier. And I'm actually looking at the marker on there, the built-in ruler. That's where I know where to break it off. That's not just an arbitrary me breaking this off. And you see the speed within which I take the obturator from the tooth, from the oven to the tooth. So just a nice flow within several seconds, put it in the tooth, and you see the speed that I'm putting it inside the canal. So I'm counting to about 7,000, 8,000 sort of seconds, and we're done, and that's it. So once it comes out of the oven, you grab the obturator, carry it over to the tooth, and on you go. It's not as if you have to be rushed. But at the same time, don't start spending half a minute and fiddling around with the obturator, because it will cool off. But it's simpler than you think. You don't have to get nervous. It's a paper point. It's just a really beautifully engineered paper point made out of really nice gutta percha, okay? So that's consistent from the oven over to the tooth. I'm going to show you again this thing later on in the webinar. Now, in this case, imagine I want to obturate, or you want to obturate this mesial root. The reason why I want to show this particular tooth is because you can see how the mesial canals, they merge apically. So you wonder, okay, how is this going to obturate one canal when the other canal is joining it? So what I want you to note is there's a paper point in the bottom canal. So it's the mesiobuccal canal here, and you see that the other mesial canal doesn't have a paper point in it. As I put in the gutta percha in the canal, I want you to look at the paper point. I want you to see what happens to that paper point. It actually comes up all of a sudden. And the reason for that is because as it fills the one mesial canal which joins the other, instead of extruding apically, if you have a good apical stop, you obturate the one mesial canal, it'll already start to backfill the other mesial canal, and that's why the paper point is going to actually rise up. So let me show you this thing. So here I am. I've got my warm GuttaCore that's just about to come out of the oven. Cotton pliers, never use your fingers. You never use your fingers to carry paper points, right? So why would you ever do that with a carrier-based obturation system? So here I am with the GuttaCore, broke off the handle. Watch the paper point as I'm obturating one of the mesial canals. So see, as I obturate one, all of a sudden the paper point comes out of the other one. Beautiful. I love seeing this. Okay? That's how nicely this fills all little nooks and voids and all that, and it starts to backfill the other canal. Take out the paper point, great, we can go in there and obturate the other one. Notice as I'm zooming in with the microscope into that unobturated canal or partially obturated canal, you can actually look inside. You see that little white area? That's the obturation already filling the second canal. Okay? So imagine both canals are 20 millimeters length individually. Well, we've obturated one to 20 millimeters, and let's say it backfilled the other one to about 5 millimeters or so. But you may not know this, and you'd wonder, well, what happens now? So now I'm worried if it's not 20 millimeters anymore, and I'm going to put my GuttaCore to 20 millimeters, am I going to extrude stuff out the apex? One of the beauties, additionally, with the system is that will not happen, because let's say now that second canal is partially filled, as you see over here. And instead of being 20 millimeters long, let's say it's 15 millimeters long. Well, what happens, because now you're obturating with GuttaCore, which is all Gutta Percha, it is all warm. What happens is, as you're obturating the canal, you have no idea how far it should go or where it'll stop. Once it meets resistance, let's say in this case at 5 millimeters, once it meets that resistance apically, then it flows coronally. That's it. It's all warm. It's not as if it's a plastic-based carrier system where no matter what, you're going to shove that thing in there to fit the 20 millimeters. Now, you'd be more likely to push stuff out the apex. Or if you're using a downpack technique where you have your pre-fitted metal plugger, whether it's night tie or stainless steel, you're going to pre-fit that thing to about 4 or 5 millimeters of the working length. And that's where, again, you're more likely to actually push stuff out the apex, because you're going to shove that thing in there even if it shouldn't be obturated to that length. So, as almost like a safety feature, if that second canal is already partially obturated, don't worry, you don't even have to know if it is or it isn't. Just obturate it to where it'll go. Once the GuttaCore reaches that resistance, it'll backfill, because it's all soft. So it's a really, really nice system. And I love highlighting here how the paper point just comes out coronally. So we've obturated that canal. You saw how quick that was to obturate the canal. Again, no gimmicks. This is beautifully simple. So how to remove the GuttaCore carrier that's now in the pulp chamber, this is how you do it. It's very simple. Spoon excavator, sharp spoon excavator. So you're going to go in there with an apical, into the orifice, apical lateral pressure. It's going to sort of snap off there. So you need a sharp spoon excavator. If it's not that sharp, then it may not work that easily. But I don't recommend using a hot instrument. I don't recommend using a high-speed burr or anything like that. Just sharp spoon excavator. Some people I know would heat up the instrument if they want. I don't, because at this point I want to let the gutta percha, the excess gutta percha, just cool off. To cool it off, either just let it cool off as you see right here in the video, or you can blow some air from your air syringe if you wish. But you'll notice now how in real time it's cooled off enough where I can just flake that thing off. Really, really simple, nothing fancy. And then after that, for even sort of more fine removal of the gutta core, I like to use a large, round, slow-speed burr. Very, very gentle sort of polishing of the floor. I'm not here to remove dentin by any means, but you'll see in a moment how I just used that large, round burr with the slow speed just to sort of flake off anything that's excess on there. So use whatever system you want. I'm not forcing you to use one system or another, but this is what's really worked very nicely for me. So here with a slow speed burr, I'm just barely brushing the floor. Really, really simple. And in the end, this is what we get. So you see on the bottom left image there, nice clean floor. That is obturation with gutta percha. That's it. It's not sealer with a tiny little gutta percha. It is gutta percha obturation in 3 dimensions. Look how nice, clean, and simple that is. And again, no gimmicks. We just did a molar. And that's with me telling you all the step-by-step. Imagine you could just fly right through it. It's really nice to see that this day and age, I'm not trying to flatter Dentsply, but it's really nice to see how Dentsply has been able to master things so nicely, and thanks to good engineering and materials, simplify this technique. This is how things should be. If something takes a lot of steps, then not that good. If you can achieve the same or better with fewer steps, everyone's life is easier and there's less room for error. So a few points I just want to highlight. I really want to make your life easier. So I've already mentioned this, but if you don't mind, I'm going to highlight this again because I love this feature of the GuttaCore. So once this GuttaCore comes out of the oven, remove the handle and use cotton pliers. Okay, really simple. And right here, I'm looking at the markers that are built into the GuttaCore. And break it off, really simple. It's very simple to do, and then you're putting it into the tooth. The reason why I like to do this is because removing the handle, first of all, gives you better maneuverability. Imagine putting in a paper point into a posterior especially, premolar, molar, and using your fingers to try and fit that paper point in the canals. It'll never happen. This is why I use cotton pliers. Same thing over here. Once you actually break off the handle and use cotton pliers, now your visibility into the pulp chamber, into the canals is so much better. And on top of that, it's just so much easier to do everything. So your visibility is easier, your handling of the obturator is so much easier. So just please make your life simple and just break off that handle. It's a phenomenal feature of this obturation system because not all carrier-based systems on the market allow you to do this. Okay, and this is a huge plus clinically. So remember, when it comes to this, break off the handle. Why does it come in handy? Because look over here. For me to do, in this case, an upper molar where the patient can't open their mouth that much, look at how easy it is for me to fit that carrier into the tooth. The opposing arch, as close as it is really not in the way. Not every patient can open their mouth like a hippopotamus and make our lives easier to obturate. This is reality here. And it'd be unfortunate if you won't be able to do the endo only because the patient can't open enough to obturate. You've done everything else, but you can't obturate enough. You say, that's it, I've done everything and I can't finish this case. On they go. Well, no, this is to make your life easier, for you to be able to complete the case. So the other tip that I like to give is with the rubber stopper. Feel free to use a rubber stopper as you wish. Feel free to use it like you do on a file to mark your length. For me personally, I don't even want to use the rubber stopper. It's there, great. It's an option for you to use. The reason is because you've got these built-in markers. So I don't even use the rubber stopper. To me, it's almost as if it's one more thing that's in the way visually when it comes to looking for that little orifice for the canal. So you can cut off the rubber stopper or slide it off nowadays towards the end of the gutta percha, not towards the handle, of course. So as you see in this video, you can just cut it off or just grab a cotton plier and sort of slide it off. But see over here, there's already those little built-in notches. So those 3 lines you see, the built-in ruler, those are your lengths. That's your ruler that's built in. So you can grab this Rubber stopper, I always remove the rubber stopper. I don't see any need for it. It's there, great if you want to use it, but I bet you the more proficient, the more comfortable you become in using this, and that'll be very quick, the less you'll need the rubber stopper, which makes it even easier to obturate and makes you realize even more how much of a small little item you have as an obturator to put into that canal. It only makes your life easier. So you could use a rubber stopper or not, but remember, never use a ruler. Use the built-in ruler that's in every carrier. The other little clinical tip, if you wish, it sort of has to do with a question I often get, which is, Manor, what do I do if there's two canals that are really close to one another, an MB1, MB2, or two mesial canals as you see over here? I'm worried that if I obturate one, then the gutta percha will overflow into the other canals. That actually used to be more of an issue with the older obturators. I gotta, again, not trying to flatter them, but I gotta give Dentsply credit for listening to clinicians, wet-fingered clinicians like myself, saying, you know, I don't like the fact you put too much gutta percha on the carrier, it's overflowing and blocking out the other canals. Well, they actually listen to you know, frontline clinicians like you and me, and nowadays it's rarely an issue. The amount of gutta percha in every carrier is almost perfect for the average length canal. But still, if you wish, if you're worried that it may overflow, then what I recommend is using paper points to just block the adjacent canal. So if, let's say, I instrumented the canal to, say, a size 40, then I would use a paper point that's maybe a size 80, let's say. It's not going to go to the apex, but it'll just block the orifice. So use large paper points to block out the adjacent canals. Now, if you have this long paper point sticking out of the tooth, you got to imagine, well, this paper point might visually block my view into the pulp chamber, and as I put in my GuttaCore, that paper point that's sticking out of the pulp chamber is also going to be in my way physically. So what I like to do is actually cut off that paper point and make sure that the top of the paper point is below the occlusal table. So let me show you in this little video what I mean. So you see the paper point in the canal, and I'll be sort of pushing it down into the canal, not forcing it down, but just to a level where I cut it so that it'll be below the occlusal table. Now I've got a blocked canal, and visually and physically, there's practically nothing blocking me from being able to put that GuttaCore into that canal in the top part of the pulp chamber you see in this picture. So that's my little trick. I've heard other people use other things, but for me, paper point, really sweet, simple, easily available, and it's my little trick there. So when you put everything together and you start thinking, okay, what works best for you? What works best for you in your practice with your patients? Think about what's out there. And you've got various systems for warm obturation. So they come down to a carrier-based obturation in the top left that's got plastic in the middle. Not good, because you can't break off the handle. If your patient can't open up like a hippopotamus, then good luck if you want to obturate a posterior tooth, because the handle will get in the way of the opposing arch. Or you have in the top right another system where it's plastic, okay, and it's got metal in there. The plastic part of it is also very, for me, it was very frustrating when I used it years ago, because now imagine trying to make a post space becomes quite an issue. Well, you got to buy a post space drill, and you got to drill out this plastic. Never that easy. It was such a hassle. So for those reasons, I already don't recommend these systems. And then on the bottom left, whatever is on the market, they're all about the same when it comes to the traditional warm downpack and backfill systems that I showed you in the beginning of the webinar. It's, you know, they're big, they're cumbersome, some of them, and they involve a heck of a lot of steps. Or on the bottom right, you see this tiny little obturator, the tiniest of all that you see out there, looks so innocent, so harmless, and when you compare it to all these other little systems that are out there, that tiny little thing on the left side of this photo is actually by far the best engineered obturation system there is, which is incredible. It's beautiful in how simple it is and how efficient it is, but that is by far the best engineered obturation gutta percha system that is out there. That tiny little thing you see on the left side of that photograph, okay? Another thing to keep in mind is, again, we're wet finger dentists. And imagine you have to think about, well, how do I mechanically move myself around logistically to try and use these various systems? Well, over here, you're going to see how, quite simply in this video, you're going to see how I'm using the traditional downpack system. So I got to hold this whole system out there. I got to make sure that I can fit it into the tooth without the opposing arch being in the way. So it's sort of quite cumbersome. Sometimes you do more acrobatic work than you think you do. You got to put in that hot instrument, as you see right now, into the canal. You make sure that it doesn't burn the lip of the opposing arch. So you got to fit that thing in there. Or you could try a carrier-based obturation system. This one happens to have plastic as a core. Well, it's not good because on the left side of the screen you can see how, well, the handle gets in the way of the opposing arch. So how do you obturate a posterior tooth? And now I have another system I'll be showing you where, again, it's plastic with metal. But again, the opposing arch is in the way. So unless it can open up like a hippopotamus, it's going to be very difficult, especially to obturate mesial canals. Or you say to yourself, man, I just wish I could just break off that handle and just put it in like a paper point. That's it. And there you go. And we just did that. Now you can maneuver this just as easily as when you're drying the canals of the tooth. That's it. No gimmicks, no catch. That's it. It's a very, very well-engineered paper point. That's how you need to look at it. But look at this obturation system versus all the other ones that I'm trying to show for obturating a molar root canal. Even if it's a premolar, you'd have the same issues over there. So I just want to make your life easy and sort of point out what's out there. And sometimes some people oversimplify things. I just want to be honest with you, okay? And this is why, unless I talk about the GuttaCore, the Gutta Percha Carrier-based obturation system, you're going to have a lot of frustrations if you try and do the 3D worm obturation, okay? So it brings me towards the end of the webinar, and this is something I love to talk about because it's something that almost gets under my skin, where people make these comments and I think to myself, they obviously have not used this system before. So it's these sort of misconceptions about GuttaCore, and they include some of the following. Some people would say, well, you know, GuttaCore can't be retreated easily. I hear it all the time, okay? I'm going to talk about that in a minute. Or some people say, oh, GuttaCore can't obturate curved canals. It only works really well on straight canals. All right, we'll talk about that. And then post-space preparations. Oh, it's such a nightmare making a post-space with GuttaCore. It's quite an issue. Well, we'll talk about that. And then the other thing is GuttaCore is more technically difficult than other systems, and GuttaCore may require more extensive of a setup. So with that in mind, let's talk about the immediate retreatment if the canal, let's say, is filled short. So let's talk about these misconceptions. So for me, the reason why I love talking misconceptions is because if anyone makes any one of those comments, I strongly urge you to ask them, have you ever actually used it? Please, because you'd be amazed how often people comment on stuff and they've never used it thinking, oh, I don't even bother using it. I just know it's not good. Well, if they haven't used it, there's no point even talking to them about it. Again, it's a real pet peeve of mine when it comes to these misconception comments about it. So first is immediate retreatments. Imagine you fill a canal short, and I'm going to show you this little video over here of me putting in this GuttaCore, and for whatever reason, I'm not going to the length that I need to go. Whether I spent too much time from the oven, I let it cool off, or maybe here's my clinical view of the same case. Either I spent too much time and it cooled off, maybe I was too fast, maybe I didn't use the corresponding size of the GuttaCore to the instrumentation, I was way off. Whatever the reason, imagine as you see in this radiograph, I'm filled way short of the apex. So the arrow is pointing to just the sealer that's there. It's not the Gutta Percha. So what do you do in this case? Because some people have these issues. Go, oh, sometimes you may feel short. It's a real problem. Well, it's not. All you have to do is you grab a headstrom file. In this case, it's a small headstrom file. Turn it clockwise so it engages part of the Gutta Percha. You go, let's say, halfway up the root. Remember, the GuttaCore hasn't fully set. The sealer hasn't fully set. Grab this thing, pull it out, and I kid you not, this is all it takes. And look at that Gutta Percha. It's come out all clean, and that's it. It's like an immediate, complete retreat. And you don't have to go back in there with your master file. You don't have to do anything. Maybe just coat a little bit more sealer in there and get right back to it. And whatever mistake you did initially, whether you're too slow or whatever it is, just make sure you do it right. That's all. But it's not the end of the world whatsoever. Imagine with the downpack technique, if you start having voids because your plugger was an issue or you couldn't have the hot injection gun touch the Gutta Percha, the apical part, there it's a nightmare. It really is, because that gooey, sticky Gutta Percha, now you got to do a full-on retreat versus what I just showed you takes just seconds. So it's not the end of the world if you obturate, you take your x-ray, you realize, no, I'm not at the length I need to be, I'm too short, then go in there with the headstrom. You got time, you're good, there's no pressure there. So that's one thing. Another one is, oh, I can't retreat Gutta Percha. Well, I can't retreat GuttaCore, excuse me. Well, it's Gutta Percha. So ask yourself, how do you retreat Gutta Percha cases? Well, just do it the same way. That's it. Okay, so use whatever instrument you want, whatever technique you want. It's Gutta Percha, whatever solvent you want to use. It's not as if all of a sudden we're using metal in there or anything like that, okay? And then on top of that, post-paste preparation. Well, it's gutta percha. How do you make a post-paste preparation in your regular gutta percha obturation? Well, here I'm using a piezo reamer. Use whatever you have. Don't go out there and start buying a whole new kit for just post-paste preparations. So whatever you have, use it. That's it. It is gutta percha. There's no catch or gimmick, remember? So again, it's another one of those comments that's thrown out there that I just don't understand. Oh, you can't retreat it, or you can't do a post-paste. Well, then that means you can't do the same things for gutta percha obturations. And then it brings me to this. Well, you can't use it on curved canals. Actually, this is probably the best system for curved canals because it is warm from the tip of the GuttaCore all the way to the CEJ area. Whereas a traditional warm obturation downpack technique, imagine these pluggers you see over here. If that plugger doesn't go to the apical third, if it doesn't go to the about 4 or 5 millimeters of your working length because the canal is curved, you're going to get voids. If your injection tip, that's injection gutta percha, can't go and touch that gutta percha left at the apical 4 or 5 millimeters, you're going to get a void. So if anything, when you have curved canals, even if you're using Nitai nickel titanium pluggers, you're still going to be hard pressed for managing curved canals like I showed you in the previous slide. And so if anything, GuttaCore is a non-issue. That is the one system that'll fill all the way down to the apex. So next one is, some people say, well, GuttaCore is more technically difficult than warm obturation. And you know, this is again coming from people who I bet you have just never even used it, never even thought about it, gave it a try. Remember these 15 steps I talked to you about? And trying the pluggers, pre-fitting the pluggers, pre-fitting the hot instrument. Well, remember the steps, how many fewer steps are involved in GuttaCore obturation and how it took roughly 8 seconds to obturate it? That's it, period, versus a downpack. So you be the judge, okay? And then in terms of the setup, it's a no-brainer. I mean, look at the setup you need for a warm obturation. You need the oven, you need the injection gun, you need the hot instrument, you need various pluggers, possibly nickel titanium pluggers for curved canals, but again, they have their limitations too, versus cotton pliers, and that's it, your obturator, okay? Very, very simple. So it brings me to one of the other misconceptions, and that is a question I get sometimes, where people say, well, you know, sometimes I get this obturation where the GuttaCore goes out the apex. Shouldn't happen often. If it does, why does it happen? Am I using too much sealer or not? Well, apical extrusion is something that is rarely I've seen due to the GuttaCore. It actually has to do more with the instrumentation or the obturation. So it's not the GuttaCore or the sealer. It's not as if, oh, you used too much sealer or the GuttaCore is wrong. It has to do with more with other aspects of the endo treatment, and it's mainly to do with the instrumentation and length determination. To backtrack a little bit and talking about basic anatomy. On the right side, you see that I have the arrow pointing in a diagram on the right side to the apical constriction, so to speak, or some people call it the minor foramina. It's the skinniest part of the canal that is most apical. That's where we need to instrument and obturate up to. Okay, that's basic endodontics. We're here working on the root canal system. So that's where the canal ends. If you don't instrument or obturate to there, or if you don't have that constriction for one reason or another, then stuff's going to go out the apex, whether you're using a downpack or GuttaCore or anything like that. So you got to respect that apical constriction, okay, or that apical stop, as some people call it. Otherwise, you're going to see what's happened in these radiographs on the left side. And we've known for years, we'd much rather not have a foreign body. I don't care how fancy the obturation system is, we'd much rather not have a foreign body in a periodontium that's just trying to heal. Okay, there's no good that's going to come out of having a foreign material irritate the periodontium. So why does this happen? Well, one of the basic things that you have to remember is that if you have an apical lesion, imagine it's outlined here with the arrows. On the left side, it's a two-dimensional radiograph of mine. On the right side, it's a cone beam image that I took of this upper canine. If you have an apical lesion, you must remember, basic anatomy, you've known this forever, that as the lesion eats, so to speak, as the infection and pathology eats away at the bone, what also happens is it eats away at the root. It resorbs the root tip, which means, as you see on the right side, the single arrow is pointing to the apex. Notice how the apex is sort of blown open. There's no constriction, there's no apical stop because the pathology ate the bone and the constriction. So now, no matter what system you're using, stuff's going to go out the apex if you're not mindful of this, okay? So here you see it in this little video where you see it's a large lesion, and there's actual resorption of the apex. You must remember this. So when you have an endo case and you see a lesion radiographically, there's a good chance that that lesion, the infection, has also destroyed the apical constriction. Okay? Please, please, please remember this. What do you do? Well, my tip for this, it's quite simple, and it's nothing new, but you got to have good working length. It is so important to have proper working length. It is such a fundamental part of endodontics that I feel we don't even talk about that enough. But that's one of the best ways to avoid having issues and stuff going out the apex. What do I mean? Well, you don't know where that constriction is. You're not going to take a cone beam 3D scan of every tooth. So your only way to know truly where the narrowest part of the canal is most apically, the only way, it's not by two-dimensional x-ray, the only way to know is use an apex locator. Not just that, you want to use a proper apex locator, not one that's jumping on you, whereas you're putting in your file and it's going, the apex locator is jumping on it. You know it's not accurate. And I've seen people love their apex locator and say, yeah, but you know what, most of the time it works okay. Well, to me it's not good enough. Because if it works okay on 3 out of 4 cases, then that poor 4th out of 4 cases patient is not going to have an endo that's substandard. So to me, I want to use an apex locator, as you're seeing here, where as I'm putting in my file, it's not jumping on me. It's a current generation, great apex locator with current technology, which is more predictable. It's not fussy, and it can give me the length that I need of that constriction. Then I know where to obturate up to, because imagine it's not an accurate apex locator. Imagine you're not even using an apex locator, and you're just going to say, well, all my obturations are going to be 1 millimeter of the working length on a 2-dimensional film. What if the canal exits 2 millimeter laterally? Happens quite often, especially in posteriors. You don't know that unless you're using an apex locator, period. So that can make the difference between do you have stuff going out the apex or not. So either you have no apical constriction because the pathology resorbed the apex, or for all you know, you're 1 millimeter long, and in that case, your master file blew open the constriction. Inadvertently, not intentional, but you didn't have the right length. Only way for you to know you have the right length is using a good current generation of an apex locator. Period. I can't stress that enough. And you got to remember that when it comes to obturation, okay? And then the final one of the final things is, again, if you have an apical lesion, as you see in this radiograph, remember that there's a good chance that as the infection ate away, so to speak, at the bone, it also resorbed the constriction. So one of the things that I very often recommend in my workshops or lectures is imagine a working length was 20 millimeters. Well, instead of obturating to 20 millimeters, when you know that there's now no apical stop because there is resorption, okay, you can almost assume that, then I would rather you obturate, say, 1 millimeter short. So if your working length is 20 millimeters, but you're assuming there's an apical stop, or if by mistake your master file went out the apex for a moment and you blew open your constriction, it's okay, it's happened to all of us, but you know you don't have constriction, then now you're going to obturate to maybe 19, 18 millimeters with your GuttaCore. Okay, this is just playing safe. I'd rather you be a tad short. But that way, you're less likely to have stuff going out the apex. So you can't blame the GuttaCore or the sealer for getting all these extrusions. It's rarely the case. It has more to do with your length determination, the way you instrumented the canal, where you instrumented it up to, that sort of thing. So it's not the obturation itself. It's rarely that. And then the last one is almost like a little pet peeve of, it's actually not a little, it's a big pet peeve of mine. And this has to do a lot with unwinding nickel titanium files. A lot of folks out there talk about files that don't separate, they don't break. Great. We don't talk enough about files that may unwind, nickel titanium mechanized files. So imagine you're using your file, you know your working length is to 20 millimeters. Well, what if you're using a file that unwinds very easily? Not great quality, unwinds very easily. So now you're trying to instrument the rubber stopper is at 20 millimeters, but it unwound and stretched a millimeter. It spun tons of times, hundreds of times potentially inside that canal before you took it out and realized, oh, it's unwound. An unwound file that's maybe 21 millimeters to begin with now is 22 millimeters. So all of a sudden, you instrumented, let's say, 1 millimeter longer than what you thought. You blew open that constriction, didn't think much of it, and then wonder why now when it comes to obturation, you're getting stuff out the apex. It's because, again, you didn't quite appreciate what's happening at the apical constriction. So unwinding files, for me, is a huge issue. We should talk about it just as much as we talk about broken files, because the damage that they do to the apical part of the root is very, very significant. So the bottom line is, please try not to use nickel titanium mechanized files that unwind, okay? Try and do your best. I don't care how cheap or popular they may be, just try and avoid that, because that has a lot of consequences when it comes to obturation. Not to mention having that file push debris out the apex, post-op pain, complications with that. on and on. Nothing good comes out of a file that unwinds easily, okay? So it's something for you to make note of when it comes to instrumenting. And just before we end, if I may, in terms of sort of what's the word on the street? What are the comments about GuttaCore? Well, I'd like to emphasize this article by Dr. Steve Buchanan. Absolute gentleman, phenomenal clinician, phenomenal endodontist, board certified endodontist, who recently in Dentistry Today magazine, one of the most widely read magazines, dental magazines in the world, commented about, discussed obturation systems. And my hat off to him for going on and on about the benefits of GuttaCore from Dentsply. It's nice to see how this is now becoming recognized, especially by people with the credentials that Dr. Buchanan has. So it brings me back to the misconceptions that are out there. And when people say, oh no, I don't like GuttaCore because of this, and that reason. Again, please do me a favor, do yourself a favor. Ask them, have you actually ever used it? Or have you ever used that in comparison to even other systems? And if they haven't, then just on you go, okay? Don't waste anyone's time because it's pointless to hear comments by people who haven't even used the system. So just to recap, and I know I covered quite a bit, we talked about the various obturation systems, the traditional worm downpack backfill obturation. Great system, very technique sensitive, a lot of steps involved. If you're happy with it, great, keep using it. But if you're having frustrations or you're starting out, you just want a nice, sweet, simple, predictable system, well, I've already shown you the GuttaCore system. I've given you a lot of clinical tips in here. I've talked about the misconceptions that are out there. And just before we finish, let me just remind you again, here I am, the canal is instrumented. This is as simple as it gets. I'm going to take out this obturator, just to recap how simple this is. Grab the GuttaCore at the ruler that's built into it. You see how I bring it over to the tooth. That's the speed, no rush, the speed you carry it over to the tooth. And you're counting 7,000, 8,000 seconds, and that's it. You're done, okay? This is where obturation, warm obturation, is this day and age, okay? No gimmicks, no tricks, that's it, okay? So with that, I'll leave it there. I want to say thank you so much for joining me. I do want to thank also Dentsply for helping me put this together. I can't thank them enough for this thing. And hopefully you got something out of this. So thank you again and have a wonderful day. Bye-bye.